Good day, I'm Kyle Corshega, the leader of Group 1, and for our group we will report RLE Module 2M, Cardiopulmonary Resuscitation or CPR. So here are the members of Group 1, Ms. Aguilar, Ms. Alerta, Ms. Amba, Ms. Arandia, Ms. Asunto, Ms. Bolofer, Mr. Kanya, Ms. Caballes, Ms. Chan, Mr. Corshega, Ms. Cordoves, Ms. Cuyos, Ms. Anor, and Mr. Astur. And here are the course learning outcomes. After 9 hours of various classroom laboratory activities, the Level 2 learners will be able to define the following terms, state the general principles of circulation, explain the ABC of basic life support, identify the causes of cardiac and respiratory arrest, enumerate signs and symptoms of cardiac arrest and respiratory arrest, list the methods of artificial respiration, discuss the following indications and contraindications of CPR and techniques of external cardiac compression, enumerate ways in checking the effectiveness of CPR, compare CPR when performing to a and or an adult child, infant, pregnant woman as to the following, and list the guidelines in performing CPR, discuss the indications, guidelines, and steps for the different vet maneuvers and techniques during emergency given various clients, and lastly, demonstrate beginning skills in CPR.
Hi everyone, this is Daphne Angie Bolifer and I will be reporting about the definition of terms for CLO number 109. So what is cardiopulmonary resuscitation? So CPR is an emergency procedure consisting of chest compressions, often combined with artificial ventilation, in an effort to manually preserve intact brain function until further measures are taken to restore spontaneous blood circulation and breathing in a person who is in cardiac arrest. So, resuscitation. Resuscitation is the process of correcting physiological disorders such as lack of breathing or heartbeat in an acutely ill patient. Airway. The airway or breathing passage is the pathway through which air flows into your lungs. Artificial respiration is generally known as the kiss of life or mouth to mouth resuscitation. It is the act of simulating respiration for a person who is not breathing or not making sufficient respiratory effort on his or her own. So let's move on to basic life support or BLS. So it is a level of medical care which is used for victims of life-threatening illnesses or injuries until they can be given full medical care by advanced life support providers. It can be provided by trained medical personnel such as emergency medical technicians and by qualified bystanders. An ALS can give basic treatment in case of cuts or injuries, whereas a BLS person does not have the right to do it. Unlike the BLS unit, an ALS unit will be equipped with airway equipment, cardiac life support, cardiac monitors, and glucose testing device. Cardiac arrest, sometimes called sudden cardiac arrest, means your heart suddenly stops beating. Respiratory arrest is caused by apnea or respiratory dysfunction, severe enough it will not sustain the body. Prolonged apnea refers to a patient who has stopped breathing for a long period of time. Crackles. So, crackles occur if the small air sacs in the lungs fill with fluid and there's any air movement in the sacs as when you're breathing. While defibrillation rather is a treatment for life-threatening cardiac dysrhythmias, specifically ventricular fibrillation and non-perfusing ventricular tachycardia. So, external cardiac compression. It is now the accepted method of treating sudden cardiac arrest. The technique is described with particular emphasis on the steps which can cause serious trauma if not properly performed. The Heimlich maneuver. It is a first procedure for dislodging an obstruction from a person's windpipe, in which a sudden strong pressure is applied in the abdomen, between the navel and the rib cage. So this is a very popular form of maneuver. The next technique is the jaw thrust technique. So it is performed by placing the index and middle fingers to physically push the posterior aspects of the lower jaw upwards while their thumbs push down on the chin to open the mouth, as you can see in the picture below. Next is the ronchi. It is a rattling or whistling respiratory sound resembling snoring. So it is caused by secretions in the trachea or bronchi, while ventilation is the act of forcing air in and out of the lungs of a person who cannot breathe easily on their own. So using a special machine called a ventilator. So the last one is wheezing. So wheezing is a high-pitched whistling sound made while breathing. It is often associated with difficulty breathing. Wheezing may occur during breathing out or expiration, or breathing in, which is inspiration. So you can base from the picture below as well.
Hello and good day. I am Justina Aguilar and I will be your reporter for the CLO, and I will be discussing the general principles of circulation. So for the general principles, we first have in here is that the circulatory system carries blood from the heart to the tissues of the body and returns the blood to the heart. It allows for nutrient, waste, and gas exchange with the tissues, as well as transport other substances such as hormones, enzymes, etc. through the body. Moreover, the circulatory system regulates blood pressure and blood flow to the tissues. Next, we have in here, it consists of the heart and the blood vessels running through the entire body. So with that said, we have two types of circulation. First, we have the pulmonary circulation. So it delivers blood from the heart to the alveoli of the lungs for reoxygenation. So it is through the alveoli that carbon dioxide is exchanged for fresh oxygen. Next, we have the systemic circulation. So it delivers oxygenated blood from the heart to the periphery of the body through a vast network of blood vessels. So with that said, we also have two types of blood vessels. So first we have the arteries. So the arteries carry blood away from the heart. The main artery, which is the aorta, branches into large arteries which lead to smaller and smaller vessels. Next, we have the veins. So the veins carry blood back to the heart. The inferior vena cava, which is the largest vein, carries the oxygenated blood to the heart. So with that said, remember to keep in mind that not all arteries carry oxygenated blood and not all veins carry the oxygenated blood. That is because the pulmonary artery is the only artery that carries the oxygenated blood away from the heart. Moreover, we have the pulmonary vein is the only vein that carries oxygenated blood back to the heart. So with all those said, let us now discuss blood circulation. So the interrelationships among pressure, flow, resistance, and the control mechanisms that regulate blood pressure and blood flow play a critical role in the function of the circulatory system. So blood circulation starts when the heart relaxes between two beats. So the blood flows from the atria, which are the two upper chambers of the heart, into the ventricles, which are the two lower chambers, which then expand. So the following phase is called the ejection period, which is when both ventricles pump the blood into the large arteries. In the systemic circulation, the left ventricle pumps oxygen-rich blood into the main artery, which is the aorta. The blood travels from the main artery to larger and smaller arteries and into the capillary network. There, the blood drops off oxygen, nutrients, and other important substances and picks up carbon dioxide and waste products. The blood, which is now low in oxygen, is collected in veins and travels to the right atrium and into the right ventricle. So this is where pulmonary circulation begins. The right ventricle pumps low oxygen blood into the pulmonary artery, which branches off into smaller and smaller arteries and capillaries. So the capillaries form a fine network around the pulmonary vesicles, which are grape-like air sacs at the end of the airways. So this is where carbon dioxide is released from the blood into the air inside the pulmonary vesicles and fresh oxygen enters the bloodstream. When we breathe out, carbon dioxide leaves our body. Oxygen-rich blood travels through the pulmonary veins and the left atrium into the left ventricle. So the next heartbeat starts a new cycle of systemic circulation.
Hi, good day. I'm Bea Francesca Chan. I'll be explaining the ABC of basic life support. The mnemonics ABC in basic life support refers to simultaneously assessing the person's airway, breathing, and circulation. So ABC is used as steps in performing cardiopulmonary resuscitation in adults, children, and infants, and these stand for airway, breathing, and circulation. So in the 2010 AHA guidelines for CPR and ECC, it recommends a change in the BLS sequence of steps from ABC to CAB. So these stand for chest compressions, airway, and breathing for adults, children, and infants. Studies show that the highest survival rates from cardiac arrest are reported among patients of all ages who have a witnessed arrest and an initial rhythm of ventricular fibrillation or pulseless ventricular tachycardia. The basic elements were chest compressions and defibrillation. So the change in sequence shows that compressions are done first to make sure circulation is ongoing in the body while only slightly delaying ventilation. In the first variation of BLS, the ABC sequence, it prioritized airway and breathing while chest compressions were delayed, but in the CAB sequence, the responder initiates compressions first, then assessment of the airway and breathing are followed. So first we have the circulation. So first, check for signs of a heartbeat or pulse. Skin appearance can also be observed as well when assessing the external appearance of a person in regards to circulation. So signs of circulation are movement and coughing. However, a person could be unconscious. So to check for the pulse, place 2 fingers on the wrist, palm facing upward, and pulse can also be checked on the side of the neck. Compressions must be done as this ensures vital blood flow to the heart, the brain, and other vital organs of the body. In the new sequence, chest compressions are performed first if the person is unresponsive and not breathing or not breathing properly. So to perform chest compressions, place the heel of your hand on the center of the person's chest and place the other heel of the other hand on top of your hand that sits atop the person's chest. So keep in mind to maintain straight arms and shoulders and push hard and fast at least 2 inches or 5 cm in adults and children and about 1.5 inches or 4 cm in infants. Allow the chest to recoil after each push. 30 compressions must be done in approximately 18 seconds. So it is reasonable for the responder to deliver at least a rate of 100 compressions per minute. Next, we have airway. So airway is a passage wherein oxygen enters the lungs. It is also the next step to do after performing chest compressions. So airway assessment must be done as well to make sure there is nothing obstructing the airway, which mainly are the nose and the mouth. So to perform the airway assessment, the following must be done. First, assess for any visible obstruction on the airway. Second, clear the airway by removing any loose obstruction from the mouth and pharynx. The third thing that we have to remember is that the tongue is the most common object of obstruction in an unconscious person. So if the mouth is not clear, place the person on their side and clear the contents. Tilt the head back by placing one hand on the forehead and the other lifting the chin. So these procedures open the airway. So once it is clear, proceed to perform rescue breaths. Now this is where breathing comes in. So breathing is the act of letting air into the lungs through the airways for gas exchange to occur to supply the body with oxygen. So in the new CAB approach, ventilation is only minimally delayed until the first cycle of chest compressions are done. So these are 30 compressions approximately in 18 seconds as blood flow is the top priority. So delay will be reduced if 2 persons or 2 rescuers are present, after which the first cycle is done, 2 rescue breaths are delivered and the cycle is repeated. So 1 rescue breath is 1 second. Repeat the cycle 5 times in 2 minutes and stop only when you are tired and and if there's another rescuer that's present, they can take over, or when help arrives, or when the person responds to CPR performed. So here on this slide, you will see that CPR is as easy as CAB. So C for compressions, push hard and fast on the center of the person or the victim's chest. A stands for airway, so tilt the victim's head back and lift the chin to open the airway. B, breathing. So give mouth to mouth rescue breaths.
Good day, this is Kyle Grishega, and for CLO 112, we have here the causes of cardiac and respiratory arrest. So, causes of cardiac arrest. Most cardiac arrests occur when a diseased heart's electrical system malfunctions. So, this malfunction causes an abnormal heart rhythm, such as ventricular tachycardia or ventricular fibrillation. And some cardiac arrests are also caused by extreme slowing of heart's rhythm, bradycardia. So we have here some causes. First is the scarring of the heart tissue. It may be the result of a prior heart attack or another cause. So a heart that's scarred or enlarged from any cause is prone to develop life-threatening ventricular arrhythmias. And next is the thickened heart muscle or cardiomyopathy. Damage to the heart muscle can be the result of high blood pressure, heart valve disease, or other causes. So, a diseased heart muscle can make you more prone to sudden cardiac arrest, especially if you have also heart failure. Next is congenital heart disease. So, when sudden cardiac arrest occurs in children or adolescents, it can be due to normal congenital heart disease. And adults who have had corrective surgery for a congenital heart defect still have a higher risk of sudden cardiac arrest. And next is heart medications. So, under certain conditions, some heart medications can set the stage for arrhythmias that cause sudden cardiac arrest. And then we have electrical abnormalities. So, these are called primary heart rhythm abnormalities and include conditions such as Wolff-Parkinson-White syndrome and long QT syndrome may cause sudden cardiac arrest in children and young people. And then we have blood vessel abnormalities. So these rare cases occur particularly in the coronary arteries and aorta. Adrenaline released during intense physical activity can trigger sudden cardiac arrest when these abnormalities are present. And lastly, we have recreational drug use, or such as the marijuana and other recreational drugs. So this can occur in otherwise healthy people. Next is causes of respiratory arrest. So first we have here smoking. So inhaling toxic chemicals like smoke or fumes can also cause acute respiratory failure. These chemicals may injure or damage the tissues of your lungs, including the air sacs and capillaries. And then next we have obstruction. So when something lodges in your throat, you may have trouble getting enough oxygen to your lungs. And obstruction can also occur in people with COPD or chronic obstructive pulmonary disease or asthma when an exacerbation causes the airways to become narrow. And then we have stroke. So patients with acute strokes may not be able to maintain adequate oxygenation and or ventilation in the absence of an acute respiratory failure. In, in fact, respiratory arrest represents a primary cause of death in the first few days after a stroke. And then we have drug or alcohol abuse. If you overdose on drugs or drink too much alcohol, you can impair brain function and hinder your ability to breathe in or exhale. And then we have infection. So infections are a common cause of respiratory distress. Pneumonia in particular may cause respiratory failure, even in the absence of acute respiratory distress syndrome or ARDS. And next is cystic fibrosis. So it is a progressive genetic disease that causes persistent lung infections and limits the ability to breathe over time. So cystic fibrosis, it affects the cells that produce mucus, sweat, and digestive juices. Next is spinal cord injuries. So respiratory dysfunction is a major cause of morbidity and mortality in spinal cord injury or SCI. which causes impairment of respiratory muscles, reduced vital capacity, ineffective cough, reduction in lung and chest wall compliance, and excess oxygen cost of breathing due to distortion of the respiratory system. And lastly, we have injury. So, an injury that impairs or compromises your respiratory system can adversely affect the amount of oxygen in your blood. So, for instance, an injury to the spinal cord or brain can immediately affect your breathing. So, the brain tells the lungs to breathe. If the brain can't relay messages to the injury or damage, then the lungs can't continue to function properly. An injury to the ribs or chest can also hamper the breathing process. So, these injuries can impair your ability to inhale enough oxygen into your lungs, resulting to respiratory arrest. For CLO 113, I will still report it. So we have signs and symptoms of cardiac and respiratory arrest. So these are the signs and symptoms of cardiac arrest. So we have three cardinal signs of cardiac arrest. One is no pulse, two, no breathing, and three, dilated pupil. So take note of that. And if you are in cardiac arrest, you may experience heart palpitations and you may become dizzy, feel fatigued or weak, you may be short of breath and as well as vomit. And immediate emergency care is needed if you or someone you are with experiences these symptoms: not breathing or difficulty breathing, no pulse, chest pain, collapse, and loss of consciousness. And now we have the signs and symptoms of respiratory arrest. So people with acute failure of the lungs and low oxygen levels may experience restlessness, anxiety, sleepiness, loss of consciousness, rapid and shallow breathing, as well as racing heart, irregular heartbeats or arrhythmias, profuse sweating. And while people with a high carbon dioxide may experience rapid breathing and confusion. Also, people with low oxygen levels may experience an inability to breathe and bluish coloration in the skin, fingertips, or lips.
Good day everyone, I am Jariv Dwezel Alerta and I will be reporting the CLO number 114, the methods of artificial respiration. The first method is the mouth-to-mouth resuscitation. This is one of the best methods of artificial methods of respiration. The main advantage of this method is giving expired air containing carbon dioxide, which stimulates the patient's respiratory center, and in this, good ventilation is obtained. For the method of use, the procedure for adults is as follows. Number 1. Place the victim on his or her back on a hard flat surface. Second is kneel at the patient's side and open and clear the airway as previously described. Pinch the victim's nose with your thumb and index finger close to the nares to prevent air from escaping during ventilation. Third is take a slightly deeper than normal breath and deliver 500 ml over 1 second, while making a seal over the victim's mouth. A good seal over the patient's mouth is essential. If a good seal cannot be obtained using this method, attempt mouth-to-nose ventilation. Fourth is remove your mouth from the patient's mouth and allow the victim to exhale passively. Provide a second breath after exhalation is complete. Fifth is after successfully delivering 2 breaths, immediately assess the circulatory status. Sixth is should the initial attempt to ventilate fail, reposition the victim's head and repeat the effort. If a second attempt at ventilation fails, the victim may have foreign body airway obstruction, and the procedures for handling such situations described elsewhere in this chapter should be followed. And lastly, assuming mouth-to-mouth ventilation is successful and the patient remains apneic, Continue the effort at a rate of 1 breath every 6 to 7 seconds to maintain the minimal adult rate of 8 to 10 breaths per minute. The procedure for children and infants is as follows. Airway opening maneuvers for children and infants are similar to maneuvers for adults, with several key differences. Anatomic differences in the infant's airway make it especially susceptible to occlusion by the tongue. The infant's head should be extended only slightly, or it should be tilted back gently into a neutral position when the head tilt or chin lift maneuver is used. So first is, if the patient is an infant, which is less than 1 year old, create an airtight seal by placing your mouth over the infant's nose and mouth. Second is, if the patient is a child between 1 year old and puberty, ventilate the victim's lungs using the same technique as would be used for an adult. Third is, provide an initial breath or over 1 second, sufficient to cause a visible rise in the chest. In infants, small puffs of air from the rescuer's cheeks are usually sufficient to achieve adequate ventilation. Fourth is, remove your mouth and allow the victim to exhale passively. Provide a second breath after this deflation pause. Fifth, after successfully delivering 2 breaths, immediately assess the pulse, which is less than 10 seconds. Sixth is, if the initial attempt to ventilate fails, reposition the victim's head and repeat the effort. A child's head may need to be moved through a wide range of positions to secure an open airway. Hyperextension of a child's neck can cause obstruction and should be avoided. If a second attempt at ventilation fails, the victim may have FBAO, and the appropriate procedures outlined elsewhere in this chapter should be followed. And lastly, assuming mouth-to-mouth ventilation is successful and the child remains apneic, continue to provide 1 breath every 3 to 5 seconds to maintain a rate of 12 to 20 breaths per minute. The second method is the mouth-to-nose resuscitation. Mouth-to-mouth ventilation cannot be performed in some situations. These include trismus, which is the involuntary contraction of the jaw muscles, also known as locked jaw, and traumatic jaw or mouth injury. Also, sometimes it is difficult to maintain a tight seal with the lips using the mouth-to-mouth method. In these situations, mouth-to-nose ventilation should be used. The method of use. First, place the victim on his or her back. Second, use the head tilt or chin lift maneuver to establish the airway, taking care to close the mouth completely. Third, inhale slightly deeper than normal and exhale into the patient's nose. Greater force may need to be applied than would be used with mouth-to-mouth ventilation because the nasal passageways are smaller. Fourth, remove your mouth from the victim's nose to allow the patient to exhale passively. If the patient does not exhale through the nose because of nasopharyngeal obstruction from the soft palate, open the victim's mouth or separate his or her lips to facilitate exhalation. Fifth, after successfully delivering 2 slow breaths, immediately assess the circulatory status. And lastly, if the victim remains apneic, maintain ventilation at the rate appropriate for his or her age. The third method is the ambu bag. A bag valve mask or BVM, sometimes referred to as an ambu bag, is a handheld tool that is used to deliver positive pressure ventilation to any subject with insufficient or ineffective breaths. It consists of a self-inflating bag, one-way valve, mask, and an oxygen reservoir. Method of use. First, an oropharyngeal airway may be inserted to prevent airway occlusion when the patient is supine. Second, the rescuer should be at the patient's head. A good seal must be achieved with the mask and the face. The pointed end of the mask must be over the nose and the curved end just below the lower lip. Third, a one-person technique requires the EC seal method where the first and second digits form a C over the mask with the thumb pressing by the nasal bridge, the second digit over the bottom of the mask by the mouth, and your remaining three digits forming an E over the mandible to hold the mask tight. There should be no gaps between the mask and the face. You can also perform the head tilt chin lift maneuver or a jaw thrust, if indicated to maintain airway patency. Fourth, in a two-person technique, the second rescuer squeezes the bag while the first rescuer uses the same EC technique with both hands. This is more effective in delivering the required tidal volume and also creates a better seal. Lastly, ensure that the soft tissue around the neck is not compressed by the rescuer's fingers. The fourth method is the mouth-to-mouth and nose. It is usually done with child under age 8 or on an infant. Method of use. First, place the child on a hard, flat surface. Second, look into the mouth and throat to ensure that the airway is clear. If an object is present, try to sweep it out with your fingers. If unsuccessful and the object is blocking the airway, apply the Heimlich maneuver. If vomiting occurs, turn the child into his or her side and sweep out the mouth with two fingers. Third, tilt the head back slightly to open the airway. Fourth, place your mouth tightly over the nose and mouth. Blow two quick shallow breaths, which is smaller breaths than you would give to an adult, and watch for the chest to rise. Fifth, remove your mouth. Look for the chest to fall as the child exhales. And lastly, listen for the sounds of breathing. Feel for the child's breath on your cheek. If breathing does not start on its own, repeat the procedure. And the last method is the mouth-to-mask. When used correctly, mouth-to-mask rescue breathing provides the same tidal volume as mouth-to-mouth rescue breathing, and is easier to use and provides larger tidal volumes than the bag valve mask technique. Since both hands of the rescuer can be used to maintain airway patency and a secure mask fit. Method of use. First, give 30 high-quality chest compressions. Second, seal the mask against the person's face by placing 4 fingers of one hand across the top of the mask and the thumb of the other hand along the bottom edge of the mask. Third, using the fingers of your hand on the bottom of the mask, open the airway using the head tilt or chin lift. Do not do this if you suspect the person may have a neck injury. And lastly, press firmly around the edges of the mask and ventilate by delivering a breath over 1 second as you watch the person's chest rise.
Discuss the following: indications and contraindications of CPR and techniques of external cardiac compression. Good day, I'm Crystal P. Cordovez, and I'll be the reporter for CLO 115. So let us now begin with the indications for CPR. First, we have CPR should be immediately performed to any person or individual who has become unconscious and is found to be pulseless. Keep in mind that it is recommended to begin performing CPR if the person is unconscious or unresponsive to prevent them losing control of their breathing. Next, perform CPR when a person is not breathing normally or if they are taking occasional gasping breaths. Take note that a person experiencing cardiac arrest may continue to breathe for a while. However, CPR compressions should be started immediately when they start gasping for breath. The third indication we have is CPR is performed when someone's heart has stopped or cardiac arrest. So begin performing CPR when the pulse is not felt. Oxygen cannot get to the rest of the body if the heart is not pumping. Chest compressions keep the blood flowing to the heart and brain until the emergency responders can take over and try other methods of resuscitation. And the last indication that we have for CPR is to perform CPR when someone is not breathing. If the person is not breathing, perform CPR to circulate oxygenated blood throughout the body. The average person can only go without oxygen for a total of 6 minutes before irreversible damage is done to the brain. If CPR is immediately performed within a time frame of 6 minutes after cardiac arrest, there is hope that the person will survive without much brain damage. Let us now move on to the contraindications for CPR. So first is we have the obvious death. Sometimes cardiac arrest is not witnessed and the victim is found unresponsive after an unknown amount of time. It's also possible that the deceased may have non-viable injuries such as catastrophic brain trauma. When discovering an unresponsive victim, one must assess the victim to see if starting CPR is necessary. The following are signs to look for: cold to the touch, or if the victim is cold to the touch, rigor mortis, livor mortis or lividity, injuries not compatible with life. So other contraindications for CPR are when an EED or AED is available and ready to use. Another trained responder or EMS personnel can take over or already takes over. You are too exhausted to continue performing CPR, or when fatigue happens, the scene becomes unsafe, and when there's an obvious sign of life, which can be seen such as breathing, purposeful movement. So if the person moves their arm or lifts their head up or grimaces or etc., this can be considered as a purposeful movement. Then we have making sounds. Make sure to listen for obvious sounds such as moaning or speaking. Then lastly, we have the eye movement. So the opening of the eyelids is not enough reason to stop CPR. Look for eye movements from the victim such as blinking, looking around, and or focusing on objects. We are now with the techniques of external cardiac compression. First, we have the hands-only CPR. So here are the steps for hands-only CPR. First, place the heel of your hand on the breastbone at the center of the victim's chest. Place your other hand on top of your first hand and interlock your fingers. Next, position yourself with your shoulders above your hands. Third, using your body weight, not just your arms though, press straight down by 5 to 6 centimeters, which is estimated to be 2 to 2.5 inches on their chest or on the victim's chest. Keep your hands on the victim's chest and release the compression and allow the chest to return to its original position. And the last step is to repeat these compressions at a rate of 100 to 120 times a minute until an ambulance arrives or when you experience exhaustion. The next technique that we have is CPR with rescue breaths. So the following are the steps. So place the heel of your hand on the center of the victim's chest. Then place the other hand on top and press down by 5 to 6 centimeters, which is estimated to be 2 to 2.5 inches at a steady rate of 100 to 120 compressions a minute. Second step, after every 30 chest compressions, give 2 rescue breaths. Third, tilt the victim's head gently and lift the chin up with 2 fingers. Pinch the victim's nose, seal your mouth over their mouth, and blow steadily and firmly into their mouth for about 1 second. Check that their chest rises, then give 2 rescue breaths. And for the last step, continue with cycles of 30 chest compressions and 2 rescue breaths until they begin to recover or emergency help arrives.
Good day everyone, my name is Sunny Jerby Kanya, and today I'll be reporting the CLO 116. So it is to enumerate ways in checking the effectiveness of CPR. So techniques of external cardiac compression. So which is to Aim for 5 sets of 30 chest compressions to 2 breaths in about 2 minutes. If you can't do mouth to mouth, stick with continuous compressions at a rate of 100 per minute. Number 1, A is for airways. Open the person's airways such as nose, mouth, and throat and check if they are clear. So remove any blockage such as vomit, blood, food, or loose teeth. Don't spend too much time doing this because CPR is the main priority. Number 2 is make sure the person is in neutral position such as on their back. Gently tilt their head back and lift their chin. Number 3 is B for breathing. Are they breathing normally? If so, gently roll them onto their side, also known as recovery position. Number 4, if they are not breathing or breathing abnormally such as grunting or grasping for air, you will need to give them CPR. And lastly, number 5 is C for CPR. So this consists of 2 techniques: 30 chest compressions and 2 breaths of mouth to mouth. For the chest compression steps, so place the heel of one hand on the lower half of the person's breastbone. So it is in the middle of their chest. These steps is number 1, place your other hand on top of your bottom hand and grasp your wrist, or you may like to interlock your fingers depending on what feels comfortable. Number 2, keep your arms straight and press down on their chest by 1/3 of their chest depth. And number 3 is release the pressure. This counts as 1 compression.
Good day everyone, I am your Nicole Martin Cuyus and together with me is Maria Christine Enor. And we are here to report the CLO number 117, the comparison of CPR when performed to an adult, child, infant, and pregnant woman. So first is the opening airway. The adult, which is 8 years of age and older, the pregnant woman, a child, which is 1 to 8 years old, is head tilt to chin lift. And for the infant, which is less than 1 year old, head tilt to chin lift, and do not tilt head back too far. In checking of pulse, the pulse at least 5 seconds and no more than 10 seconds. For the adult and the pregnant woman is a carotid pulse. If no pulse, then start CPR. For the child, carotid pulse, and if no pulse or pulse is less than 60 with poor perfusion, start CPR. For the infant is in brachial pulse. If no pulse or pulse less than 60 with poor perfusion, start CPR. In breaths, for the adult, pregnant woman, child, and infant, is to give 2 breaths, 1 second per breath. In compression area, center of the chest between the nipples for the adult, pregnant woman, and child. And for the infant, just below the nipple line on the breastbone. For the depth of compression, for the adult and pregnant woman, 1.5 to 2 inches or 5 centimeter. For the child, half depth of chest or 5 centimeter. And for the infant is 1/3 depth of chest or 4 centimeter. And that would be all for my part. I will now pass to the next reporter, Ms. Christine Inor, to continue.
Maria Cristina Yanor, and I am the next reporter to continue on the comparison of CPR. So in continuation, we have how to compress. Starting off with adults ages 8 years old and older. First is to place the heel of one hand on the breastbone just below the nipples, and then place the heel of your other hand on top of the first hand. Position your body directly over your hands. Give 30 chest compressions. These compressions should be fast and hard. Press down about 2 inches into the chest, and each time, let the chest rise completely. Next, we have giving compressions to pregnant women. There is no scientific evidence to support changing your hand placement for chest compressions on pregnant women. However, chest compressions on a pregnant woman is made difficult by flared ribs, raised diaphragm, obesity, and breast hypertrophy, which is why prior to performing chest compressions, it is wise to manually move the uterus to the left. While doing this, place the victim in a comfortable position, which is usually lying on a flat surface. Start with the compressions, without alternating the procedure with rescue breathing. Try to perform only hands compressions to ensure that the major veins have enough blood flow. Continue to make 30 compressions followed by 2 breaths until exhaustion. Next is to give compressions to child ages 1 to 8 years old. Place the heel of one hand in the center of the chest while your other hand on top and your fingers interlace and off the person's chest. Position your shoulders directly over your hand and lock your elbows. Push down hard and fast about 2 inches at a rate of 100 to 120 beats per minute and allow the chest to return to normal position after each compressions. And lastly, to an infant who are less than 1 year old, is to place both thumbs side by side on the center of the baby's chest, just below the nipple line. Use the other fingers to encircle the baby's chest towards the back, providing support. Using both thumbs at the same time, push hard down and fast about 1.5 inches at a rate of 100 to 120 beats per minute. Allow the chest to return to its normal position after each compression. As for the next category, which is the rate of external cardiac compression to an adult, pregnant woman, child, and infant, it is considered as true to all age groups, which is giving continuous compressions at a rate of 100 to 120 beats per minute. The idea is to be exact or between 100 and 120. As for the ratio of compression and ventilation, it is recommended to do 30:2 regardless of having 1 or 2 rescuers, meaning 30 compressions and 2 breaths are given to both adults and pregnant women. Same ratio is observed to both child and infant, but only when there is 1 rescuer, which is a ratio of 30:2. However, when a second rescuer arrives to help with CPR on children or infant, the ratio changes from 30:2 to 15:2. So that is it for the comparison of CPR when performed to two or an adult child, infant, pregnant woman. Thank you.
Hi guys, my name is Frolan Nestor. I'm going to report along with Isa and Jana, which is the CLO number 118, less the guidelines in performing CPR. So before performing CPR on adult, use the following preparation steps. So for step 1, call 911. First, check the scene for factors that could put you in danger, such as traffic, fire, or falling masonry. Next, check the person. Do they need help? Tap their shoulder and shout, like, "Are you okay?" If they are not responding, call 911 or ask a bystander to call 911 before performing CPR. If possible, ask a bystander to go and search for an AED machine. People can find this in offices and many other public buildings. Step 2. Place the person on their back and open their airway. Place the person carefully on their back and kneel beside their chest. Tilt their head back slightly by lifting their chin. Open their mouth and check for any obstruction such as food or vomit. Remove any obstruction if it is loose. And if it is not loose, try to grasp it may push it farther into the airway. So step 3, um, check for breathing. Place your ear next the person's mouth and listen for no more than 10 seconds. If you do not hear breathing or you only hear occasionally gasps, begin CPR. If someone is unconscious but still breathing, do not perform CPR. Instead, if they do not seem to have a spinal injury, place them in a recovery position. Keep monitoring their breathing and perform CPR if they stop breathing. For step 4, perform 30 chest compressions. As you can see in the pictures, adult, child, infant, there are different kind and perform chest compressions. Place one of your hands on top of the other hand and clasp them together with the heel of the hands and straight elbows. Push hard and fast in the center of the chest, slightly below the nipples. So push at least 2 inches depth. Compress their chest at a rate of less 100 times per minute. Then let the chest rise fully between compressions.
I'm Aizaranjan and I'm going to continue reporting for step 5 and 6. So for step 5, perform 2 rescue breaths. Making sure their mouth is clear, tilt their head back slightly and lift their chin. Pinch their nose shut, place your mouth fully over theirs and blow to make their chest rise. If their chest does not rise with the first breath, re-tilt their head. If their chest still does not rise with the second breath, the person might be choking. For step 6, repeat. Repeat the cycle of 30 chest compressions and 2 rescue breaths until the person starts breathing or help arrives. If an AED arrives, carry on performing CPR until the machine is set up and ready to use. Next, CPR for children and infants. The CPR steps for children and infants are slightly different to the steps for adults as below. Preparation steps. To perform CPR on an infant or child, use the following preparation steps. Step 1. Call 911 or give 2 minutes of care. First, check the surrounding area for factors that could put you in danger. Next, check the child or infant to see whether they need help. For children, tap their shoulder and shout, "Are you okay?" For infants, flick the sole of their foot to see if they respond. If you are alone with the child and they are not responding, give them 2 minutes of care and then call 911. If there is a bystander, ask them to call 911 while you give 2 minutes of care. If possible, ask a bystander to go and search for an AED machine. Offices and other public buildings tend to have this. If the child does respond, call 911 to report any life-threatening conditions. Step 2. Place them on their back and open their airways. Place the child or infant carefully on the back and kneel beside their chest. Tilt their head backward slightly by lifting their chin. Open their mouth, check for any obstruction such as food or vomit. If it is loose, remove it. If it is not loose, do not touch it, as they may push it farther into their airways.
For step 3, check for breathing. Place your ear next to their mouth and listen for around 10 seconds. If you do not hear breathing or you only hear occasional gasps, begin to administer CPR. For CPR steps, use the following steps to perform CPR on a child or infant. For step 4, perform 2 rescue breaths. If the child or infant is not breathing, perform 2 rescue breaths with their head tilted backward and their chin raised. For step 5, perform 30 chest compressions. Kneel beside the child or infant. For step 6, repeat. Repeat the cycle of rescue breaths and chest compressions until the child starts breathing or help arrives.
Good day everyone, this is Asunto Daryl Ann and today I will be reporting the CLO 119. So this is to discuss the indications, guidelines, and steps for the different maneuvers and techniques during emergency given various clients. So first we have the Heimlich's maneuver. Indication: choking due to severe upper airway obstruction due to a foreign object. So it is signaled by inability to speak, cough, or breathe adequately. And these are the steps in doing the Heimlich's maneuver. First, you should determine if there is a severe airway obstruction. And then you should look for signs of difficulty speaking, coughing, or breathing. Then look for hands clutching the throat, which is the universal distress signal of severe airway obstruction. Then you should ask, "Are you choking?" And then followed by encouraging the person to cough if they are able to speak and breathe, but do not do any airway clearance maneuvers. Instead, schedule a medical examination. Then if the person nods yes or cannot speak, cough, or breathe adequately, that means that the airway is blocked and airway clearance procedures are required. And here are the steps in treating the choking conscious adult or child. First is to stand directly behind a choking adult or kneel behind a child. Then begin with abdominal thrusts for people who are not pregnant or obese. Do not chest thrusts for obese patients and women in late pregnancy. To remove the obstruction, alternate between sets of abdominal thrusts or the Heimlich maneuver, the chest thrusts, and back blows as needed. Then continue until the obstruction has been eliminated or sophisticated airway management techniques have been developed. And if the person loses consciousness, start cardiopulmonary resuscitation, or what we call the CPR. And before providing rescue breaths, examine inside the patient's mouth after each set of chest compressions and remove any obvious impediment that can be reached. And do not do blind finger sweeps. Steps in doing Heimlich maneuver to conscious adult or child. First, encircle the patient's midsection with your arms, and then clench one fist and place it midway between the umbilicus and xiphoid. Third is to grab the fist with one other hand and then deliver a firm inward and upward thrust by pulling with both arms sharply backward and upward. And then lastly, rapidly repeat the thrust 6 to 10 times or until the object is expelled and the person can breathe or cough on their own. So as you can see in this picture, this is how you do the Heimlich maneuver. Guidelines in doing the Heimlich maneuver on a pregnant woman. So you should place your hand a little higher on a pregnant woman's torso, around the breastbone space. Place the person on their back and try to clear the airway with your finger in a sweeping motion if they are unconscious. Begin CPR if you're unable to dislodge the stuck object. For infant, if the person who is choking is younger than 1 year, you need to follow these guidelines. First, hold the newborn on your forearm, which should be resting on your thigh while sitting down. With the heel of your hand, softly give 5 back blows. If it does not work, place the infant on your forearm and thigh with their head lower than their body. Then, place 2 fingers at the center of their breastbones and perform 5 quick chest compressions. Then the back blows and chest thrusts should be repeated until the object is removed and the infant is able to breathe or cough on their own. If you're all by yourself and no one's with you, you need to remember and follow these guidelines. So first, make a fist with your thumb side in and position it directly over your navel. With your other hand, grab the fist and drive it inward and upward at the same time. Perform 5 of these abdominal thrusts. Then repeat until the object is expelled and you can breathe or cough on your own. You can also thrust your upper abdomen against a hard edge like the corner of a table or counter or back of a chair. So just like in this picture, you can do this if you're choking and nobody's with you. Now let's move on to the second technique. This is the jaw thrust technique. So we have 4 indications here. First, for patients who are obtunded or unresponsive should have a treatment for suspected upper airway obstruction. Next is the apnea or impending respiratory arrest is treated as part of the initial emergency care. And then improvement of airway patency during BVM ventilation and sometimes during spontaneous breathing. And of course, patients who have apnea. And for steps, first, kneel behind the patient's head, keeping the head in a neutral position with the head, neck, and spine aligned. Make sure your fingertips are at the same angle of the jaw and your hands are on the side of the face or the mandible. Third, gently lift the jaw to open the airway. Take care not to tilt the neck. The tongue is moved forward in the mouth by the movement of the jaw, which opens the airway. And lastly, do not put fingers in the mouth to assist the jaw thrusts. So there are also guidelines in doing the jaw thrust technique. First, place your palms on the patient's temples and your fingers beneath the mandibular rami while standing at the head of the stretcher. Second, avoid extending the neck in patients who may have a cervical spine injury. And then, with your fingers, lift the mandible upward until the lower incisors are higher than the upper incisors. The tongue and mandible are lifted together in this procedure, allowing the upper airway to be cleared. And then make sure you solely pull or push up the mandible's bony portions. This airway may be obstructed by pressure on your neck's soft tissues.
This is Mary Jeannie Caballos, and today I will continue discussing 11.3 to 11.5. 4 back blows for infants. For its indications, first, when someone cannot breathe because of food, a toy, or other object is blocking the throat or windpipe. Create a strong vibration and pressure in the airway, which is often enough to dislodge the blockage, allowing them to breathe again. Support their head while you hold them in the position. If the person is able to cough forcefully, the person should keep coughing. If the person is choking and can't talk, cry or laugh forcefully. The American Red Cross recommends a 5 and 5 approach to delivering first aid. Steps. Number 1. Give up to 5 back blows. Lay the baby down on your forearm. Hold the baby's mouth open with your fingers. Use the heel of your hand to give the baby a firm back blow between the shoulder blades. Give up to 5 back blows. Check between each blow to see if the blockage has cleared. 5 chest thrust. If the blockage hasn't cleared, lay the baby on their back. Put 2 fingers in the center of the chest and give up to 5 chest thrusts. Like CPR, compressions but slower and sharper. Check to see if the blockage has cleared between each thrust. Blockage has come loose or been removed. Remove the object with your little finger. Put the baby into the recovery position on their side with their head tilted down. If the baby is still choking, alternate 5 back blows and 5 chest thrusts until emergency help arrives. If the baby becomes unconscious, start baby CPR. For its guidelines, Back blows for babies under 1 year. Sit down and lay your baby face down along your thigh or forearm, supporting their back and head with your hand. Give up to 5 sharp back blows with the heel of one hand in the middle of the back between the shoulder blades. Back blows for children over 1 year. Lay a small child face down on your lap as you hold a baby. If this isn't possible, support your child in forward leaning position and give 5 back blows from behind. For unconscious child with choking, if a choking child is or becomes unconscious, put them on a firm, flat surface and shout for help. Call 911, putting the phone on speakerphone so your hands are free. Don't leave the child at any stage. Open the child's mouth. If the object is clearly visible and you can grasp it easily, remove it and start CPR. For chest thrust technique, for its indications, when the airway obstruction is severe and life is endangered, if the choking person can speak, cough forcefully, or breathe adequately, no intervention is required. For its steps, encircle the patient's midsection with your arms. Clench one fist and place it on the lower half of the sternum. Grab the fist with the other hand. Deliver a firm inward thrust by pulling both arms sharply backward. Lastly, rapidly repeat the thrust 6 to 10 times as needed. For its guidelines, chest thrust for children under 1 year. Lay your baby face up along the length of your thighs. Find the breastbone and place the fingers in the middle. Give 5 sharp chest thrust pushes, compressing the chest by about a third. Finger sweep. For its indications, originally recommended as a method for parents to help choking babies and toddlers, the finger sweep involves running your finger through the choking person's mouth in an attempt to dislodge the food and other objects that is blocking the airway. While we understand the appeal of this common sense approach, evidence has shown that it's not only ineffective in the vast majority in choking cases, but it also can make the situation much worse. For its steps, step 1, with the victim's face up, open the victim's mouth by grasping both the tongue and lower jaw between the thumb and fingers and lifting the jaw. This action draws the tongue away from the back of the throat and away from a foreign body that may be lodged there. This step alone may partially relieve the obstruction. For step 2, insert the index finger of the other hand down along the inside of the cheek and deeply into the throat to the base of the tongue. Step 3, use a hooking action to dislodge the foreign body and maneuver it into the mouth so that it can be removed. Lastly, for its guidelines, that can be done quickly and require no special equipment except a set of medical gloves. A foreign body can be removed by performing a finger sweep. This procedure, however, must be performed on unconscious victims only, though not on seizure victims. Open the infant or child's mouth. If an obvious object is seen, attempt to remove it with a single finger sweep. Blind or repeated finger sweep are not recommended because the object could be pushed deeper in the pharynx.